Now that we've talked about the electrophysiology of the heart, the SA node, the AV node, the Purkinje fibers, depolarization, repolarization, the the plateau phase, the electrocardiogram, ECG, the P wave, the QRS, the T, and basically have talked about how the signal is sent for the contraction of the heart. Now we actually have to get into the actual cardiac cycle. So actually what happens now that we know how the signal is sent, sort of like the electrics behind the heart contraction. Now we have to look at the physiology behind the actual heart contractions and that whole process. Remember, it's a rhythmic contraction. So it's going to contract in a certain way so that it fulfills its purpose, which is to pump the blood throughout the body and to keep the blood flowing in one direction. The amazing heart. All right, so mechanical physiology, is a quick introduction, is the process by which blood fills the cardiac chambers, that's your atria and your ventricles, and is pumped out of them. So the blood comes in the right atria, then down to the right ventricle, pumped through the pulmonary circuit, then into the left ventricle, and fills the left ventricle, then left atria, and then into the left ventricle, and then it's pumped through the systemic circuit. Okay. The cardiac muscle cells contract as a unit to produce one coordinated contraction. Right. That's why they have those gap junctions that connect the different cardiac muscle cells so that they can communicate very quickly with each other and have a coordinated contraction, which is known as your heartbeat. Muscle cells are arranged in a spiral pattern, producing a ringing action. So like a ringing action. And the pressure that they're able to exert on the fluid, which is blood, that's in the chambers, allows the blood to flow, but also that pressure prevents the backflow. So because it helps close the valves. So the cardiac cycle is the sequence of events from within the heart, from one heartbeat to the next. Remember the R remember the QRS. R is when the ventricles are fully depolarized. So from R to R, right? That's your cardiac cycle. All right, so what happens? So blood flows in response to pressure. I like to use the example of a hose at times, and you talk about blood flowing through the arteries, but it also kind of helps you understand some sort of your water hose can help you understand the blood flow in the heart as well. If you increase the pressure on a fluid, it's going to flow. All right, very simple. If I take a balloon and fill it with water and I start to squeeze it, that water is going to, expand the balloon or eventually pop the balloon and flow out. So I've increased the pressure and that causes it to flow. So blood flows in response to pressure gradients as ventricles contract and relax. Pressure in the chambers change, causing blood to push on the valves and open or close them. Right? So we want to pay attention to the blood pressure, the pressure that is exerted by the blood on the valves, and the pressure that is in the ventricles. And so we'll pay a lot of attention to that. So when the ventricles contract, the pressure rises above those in the right and left atria and in the pulmonary trunk. So in the ventricles, which are inferior to the atria, when they contract, it causes the AV valves, atrioventricular valves. Remember, we have the tricuspid and bicuspid atrioventricular valves to be forced shut, so the blood, that prevents blood going back into the atria. But then also the semilunar valves are forced open by outgoing blood. So blood, due to the changes in pressure, that when left ventricle contracts, closes the AV valve, but then eventually forces open the valve to the systemic, the aortic valve to the aorta and the rest of the systemic circuit. So all of that is created by the pressure that's created. And remember, this pressure is created due to the musculature. The squeeze, think of a balloon. If I took a balloon filled with water and started to squeeze it, that pressure is created by that squeezing. That squeezing is the muscles. In this case, in the heart, the muscles in the myocardium, right, in the musculature of the heart. Right, so that's just showing you a diagram of that. So the semilunar valve, the aortic valve, is pushed open and blood flows out that way, while the mitral valve, bicuspid valve, is due to the pressure of the left ventricle contracting, and also the papillary muscles and chordae tendineae, it is closed. And so you have the blood flowing this way. We do not want the blood to flow back into the left atrium. Hopefully that all makes sense. When the ventricles relax, the opposite occurs. Pressure in the ventricles fall below those in the atria and in the pulmonary trunk and the aorta. Now the higher pressure in the atria forces AV valves open, allowing blood to go from the atria to the ventricles. Higher pressure in the pulmonary trunk and aorta push cups of the semilunar valves closed. All right, so the reverse happens when the ventricle relaxes. Ventricle relaxes, pressure decreases, higher pressure in the aorta as compared to the pressure in the ventricle causes this to close, the semilunar, this aortic valve, but then the higher pressure in the ventricles and the lower as compared to the higher pressure in the atria, I keep saying ventricles, higher pressure in the left atria as compared to the left ventricle causes the mitral valve, bicuspid valve to open, and therefore now blood flows into the ventricle. So it's all controlled by pressure. Everybody's probably heard of a stethoscope, or you have used one if you're in the medical field. If you go to the doctor, normally the doctor will use it to listen to your heart. Completely common. You can listen to the sounds of the heart. Just like in ECG or EKG, you can look at the electrical signals of the heart, the actual depolarization and repolarization of the muscles in the heart. But with a stethoscope, you can listen to sort of the mechanics of the heart. So under normal conditions, blood flow through the AV and semilunar valves is relatively quiet. The sound occurs when the valves close. They're actually not due to the slamming shut, but result from vibrations of ventricular and blood vessel walls, right? So there are two heart sounds. This is what we need to know. S1 or lub when the AV valves close, and S2 or dub when the semilunar valves close. AV, atrioventricular valves, valves between the atria and the ventricles, and then semilunar valves when the semilunar valves close. Those lead to the pulmonary and systemic circuit. And the S1 is typically longer and louder than the S2. Right, so clearly someone who is listening to these, who knows what they're doing, medical professional, has been trained in the sound of hearing the lub dub, hearing the AV valves, the closing of the AV valves, and the vibrations from that, and the closing of the semilunar valves. One of the more common findings is when you do this is an audible sound called a heart murmur, and this is when blood flow through the heart is turbulent. And that can generally be caused by defective valves. Remember, we talked about valves not closing all the way, and stenotic valves, valves that have become calcified and maybe have difficulty closing. Also, you can have defective chordae tendineae, the heartstrings, the tendons connected to the papillary muscles, or you can have holes in the interatrial or interventricular septum. Interatrial, the septum dividing the atrium, or the left and right atria, or interventricular, the septum dividing the left and right ventricle. So these are all issues that can potentially be noticed by the doctor listening to your heart. And that's why when you get a physical, one of the things that they do is use a stethoscope and they listen to your heart, because the heart is a very important organ, as I've said before, one that we want to definitely take care of. Here is the where the placement of the stethoscope and the sounds that you would hear. And sometimes in the past, we've done this in the lab where we've allowed students to actually use the stethoscope and place it on each other. Obviously, it's not invasive. You're not cutting somebody, so you can just listen to somebody's heart pretty easily. Stethoscopes are pretty easy devices to use, but it can be a little tricky the first time, not, if you don't know exactly what you're doing. But you can, if you notice when a doctor does it, they put it in a couple of different locations. These are the different locations that you put it in order to hear the different sounds. All right, the aortic valve, the tricuspid valve, tricuspid going from your right to your right atria, left to left atria, right atria to right ventricle, mitral valve, left atria to left ventricle, pulmonary going from the ventricle to, going through the pulmonary valve from the right, which is from the right ventricle to the lungs, aortic valve from the left ventricle to the systemic circuit, to the aorta. And this is where these are the locations where you would place the stethoscope in order to hear that particular sound, right? Which are located here. Okay. So each cardiac cycle consists of one period of relaxation. And these are terms that you probably heard of and maybe didn't know exactly what they referred to, but hopefully now that you're taking Anatomy and Physiology Part 2, you'll learn and you'll be better informed next time you go to the doctor. But each cardiac cycle consists of one period of relaxation, diastole, sometimes people say diastole, and one period of contraction, systole, for each chamber of the heart. So the atrial and ventricular diastoles and systoles occur at different times as a result of the AV node delay. Both sides of the heart are working to pump blood. But remember, each part of the heart, while each part contracts, it has to contract, each part also has to have a period of relaxation, remember, to fill with blood. Right? So the cycle is divided into four main phases, defined by actions of ventricles and positions of valves. So filling, contraction, ejection, relaxation. These are important. Filling, you got to fill with blood. Contract, the muscles begin to contract. Ejection, the blood is moved out of that chamber. And then relaxation, that muscle has to relax. Then it starts over. You fill with blood again. All right, so let's go through and understand this what we call this what we're calling the cardiac cycle. Okay, so ventricular filling phase of the cardiac cycle, period which blood drains from the atria to the ventricles. Right, so that's the first step. Like I said, filling, contraction, ejection, relaxation. Right, so the filling, very simply, pressure in the left and right ventricles are lower than in the atria, so the pressure is lower. So higher pressure, remember, fluid moves from high pressure to low pressure. Remember that. So the pressure in their left and right ventricles are lower than the atria. So the pressure is higher in the atria, higher in the pulmonary trunk and in the aorta. So because the pressure in the ventricles right now, they just come out of the relaxing phase, the pressure is lower in the ventricles. So blood is going to flow into the ventricles. Right? It's not going to flow into the ventricles from the pulmonary trunk or the aorta, because that would be flowing backwards. So those valves will close, so the blood doesn't flow backwards. But the atrioventricular valves, the bicuspid and tricuspid valves, will allow the blood to flow down into the ventricles. Nearly 80% of total blood volume of the atria drains passively into the ventricles. So just due to the pressure difference, 80% of the blood from the atria will pass right into the ventricles. This is why we talked about if you have atrial fibrillation, we talked about it's not life-threatening. So because even if the atria don't have a significant contraction, blood can still flow from the atria to the ventricles. Initially, the atria are in diastole, but as the blood continues to drain, pressure gradient becomes smaller and filling slows. At this point, the atrial systole takes place, so the atria contract and eject variable volume of blood in the ventricles as much as remaining 20% of blood volume. Right? So even without contraction, 80% of the blood can flow from the atria into the ventricles due to just the differences in pressure between the two. Then the atria contract and the rest of the blood, up to the remaining 20%, the rest of the blood in the atria can then be forced into the ventricles. So at the end of atrial systole, each ventricle contains about 120 milliliters of blood, which is called your end diastolic volume. So this is blood that has gotten into the ventricles while the ventricles are basically at rest during their filling phase. Right, this is a picture of that. Atria are filled with blood. Atria right and left are filled with blood due to the higher pressure in the atrium, lower pressure in the ventricles. Blood naturally flows down to the ventricles, 80% of it. Then the atria go into their systole, they contract and force up to the remaining 20% of blood that was left in there into the ventricles. Yeah, I think that explains pretty much everything on that slide. Now we have the beginning of ventricular systole. Occurs during shortest phase of the cardiac cycle. You have this isovolumetric contraction. So pressure in the ventricles rises rapidly as ventricles begin to contract. High pressure closes the AV valve and causes the S1 heart sound. So once you get to part 2, these valves will close, which I think is on the next slide. Here we go. Isovolumetric contraction. This pressure increases in the ventricles. The AV valves, tricuspid and bicuspid valves, will close. But this phase is called isovolumetric because the actual volume, the blood in the ventricles doesn't change shape yet. No more blood is coming in, no blood is leaving just yet. You just are increasing the pressure. All the valves are closed at this point. All right. Pressure is not yet high enough to push open the semilunar valves. Okay, so that's your isovolumetric contraction. And then we have ejection. So at the beginning of the ventricular ejection phase, pressure in the ventricles rises higher than in the pulmonary trunk and the aorta. This pushes open. So now the pressure is increased and the ventricles can start to eject blood into the systemic and the pulmonary circuits. Rapid outflow of blood from ventricles occurs. Approximately 70 milliliters of blood pumped from each ventricle, and about 50 milliliters of blood remains in each ventricle. That's your end systolic volume, ESV. Right. That's your ejection phase. AV valves are closed. Atrial diastole continues. You open your semilunar valves. Blood is ejected into the pulmonary artery and aorta. And then you have isovolumetric relaxation. Brief occurs as ventricular diastole begins. The ventricles begin to go into their resting phase. Pressure declines in the ventricles. The semilunar valves shut because the pressure gets higher in the aorta and the aorta and the pulmonary arteries gets higher. So therefore that pressure shuts the semilunar valves. Those shut. Pressure in the ventricles is somewhat higher than the atria, so the AV valves remain closed. And now blood is neither going in or out of the ventricles, and they go into their rest. Okay. Ventricle diastole begins. All right, this is a nice diagram that sort of shows you the pressure, ventricular filling phase, isovolumetric contraction phase, ventricular ejection phase, isovolumetric relaxation phase. This is in the right ventricle, which is, remember the right ventricle is a low pressure circuit because it's only pushing blood to the lungs. Then you also have the left ventricle, and how you see how much higher the pressure is in the left ventricle. Remember, the left ventricle has to push blood throughout the entire body. So it creates much more pressure, much stronger pressure. All right. This is showing you the cardiac cycle as far as the ECG, electrocardiogram, P wave, arterial, atria depolarization, QRS, your ventricular polarization, T wave, your ventricular repolarization, the sounds, closing of the atrial ventricular valves. Part 2, closing of the semilunar valves to the systemic and pulmonary circuit. Right. This is after the ventricles have been ejected, and now those valves need to close as the ventricles go into relaxation. This first valves close after the atria has had the atrium have had their depolarization, then have drained into the ventricles. The ventricles depolarize and therefore close the atrioventricular valves, and you get the first sound. Right, so this is the ECG matched up with the heart sounds, matched up with the pressure. Notice how pressure increases greatly when you go into the ventricular contraction. That's where you have the highest amount of pressure. Depolarization of the ventricles, closing of the valves back between the ventricles and the atrium, high pressure, ejection of blood through the pulmonary and systemic circuits. And then here at the bottom chart, you have volume changes in left heart, and this is your end diastolic volume. When the ventricle is full, we're going to talk about stroke volume, and then your end systolic volume. So after you filled up the ventricle, this is the highest volume. Then you eject, and then the remaining blood left in that ventricle is your end systolic volume. Right? Be able to understand that. All right, and so now we go into cardiac output and regulation. This is our last section for this chapter. So we have a lot of information about blood and a lot of information about the heart so far. But the heart undergoes 60 to 80 cardiac cycles or beats per minute. So on average, you go to the doctor, you get tested, listen to your heart, or you can check your pulse. It should be somewhere between 60 to 80 beats per minute. Obviously, it's a lot higher when you're engaged in some type of exercise, like walking, picking up boxes. Your body's moving, and obviously it's also, hopefully it's obvious that it's a little bit lower toward the lower range when you're sleeping. Your blood doesn't have to, the demands on your body are not as high. Therefore, your heart doesn't have to pump as fast. So when you're laying down, it's probably it's usually when it's at its slowest, unless you're like stressed about something. And when you're moving around, standing up, picking up things, moving boxes, running around, going up steps or up hills, something like that, which are high demand activities, it's going to be higher. Okay. But generally the average is 60 to 80 cardiac cycles or beats per minute, or, R to R, 60 of those, 60 to 80 of those, if you're looking at the ECG. All right. So that seems like a lot, right? You're filling, you're filling, relaxing, filling, contracting, ejecting over and 60 times, 80 times in 1 minute. So this all happens pretty fast. All right, so that value, that 60 to 80 beats per minute, is known as your heart rate. Heart rate is one determinant of cardiac output, and that's a very important term that we want to discuss. Cardiac output is the amount of blood pumped into the pulmonary and systemic circuits, right? Both. The amount of blood pumped into the pulmonary and systemic circuits in 1 minute. So the amount of blood basically pumped out of your heart in 1 minute. Like, to add all the pumps together, add both the right ventricle and left ventricle together, and all the blood that's pumped out in 1 minute, that's considered your cardiac output. Cardiac output is also determined by the amount of blood pumped in one heartbeat, which is called your stroke volume. So stroke volume, amount of blood pumped in one heartbeat, that's an important term as well. You saw that in the last graph. So remember, heart rate, how many times your heart beats. Stroke volume is actually the amount of blood per pump. So if we know the amount of blood per pump, so if we had, just for an example, if we had 5 heartbeats a minute, and we had, let's say, for instance, let's say 1 cup of blood per beat, then if you wanted to find out what your cardiac output was, it'd be 5 times 1, which would be, so it'd be 5 cups of blood per minute. That would be an example, just an easy example. So your stroke volume is how much blood is pumped per beat. Your heart rate is how many beats per minute. Your cardiac output is the combination of beats per minute and how much your stroke volume is per beat. All right, so how do we put those together? How do we figure these out? Hopefully I didn't confuse you. And if I did, hopefully it'll make sense in a little bit. So stroke volume and heart rate must be known to calculate your cardiac output. All right, so stroke volume can be calculated by subtracting the amount of blood in the ventricle at the end of the contraction, which is your end systolic volume, from the amount of blood in the ventricle it has during the filling, end diastolic volume. So when the ventricle is filled with blood, at the end of that filling phase, that's the end diastolic volume, which is about 120 milliliters. After it beats, the ringing motion, after it beats, it contracts, it beats, it shoots the blood out. If it shoots, you get rid of if your end diastolic volume is 120, right? That's when it fills up. If after it has released the blood, it has pushed the blood along, you have 50 milliliters left in the ventricle. That's what I'm trying to say. Then we know you've gotten rid of 70, right? So if I filled up to 120, I contract and push out, and I have 50 left in the ventricle, that means I've pushed out 70, right? So that's where we use the end diastolic volume and the end systolic volume to get our stroke volume, right? To find the cardiac output, we multiply heart rate by stroke volume. So the example given here is 72 beats per minute, which is right around average, times 70 milliliters. That's our stroke volume. Is how much blood we push out every beat. That would give us 5,040 milliliters per minute, or about 5 liters. So your resting cardiac output averages about 5 liters per minute. It's a lot. That's a lot of blood being pumped. Your right ventricle pumps about 5 liters into the pulmonary circuit. Left ventricle pumps the same amount into the systemic circuit in 1 minute. So the normal adult blood volume is about 5 liters. So your entire blood supply passes through your heart every minute. Let me say that again. Your normal adult blood volume, so the total amount of blood in your body, is about 5 liters. So basically, what we're saying here is that all of the blood in your body passes through your heart every minute. All the blood in your body. So there's 5 liters of blood in your body. Your body pumps about 5 liters every minute. So it pumps all the blood in your body once a minute. It's telling you how important. That shows you exactly how important. And it needs to do that. That's another thing. It needs to do that for you to be alive. That shows you how important your blood supply and your blood supply and also your heart is. All this is happening very fast and taking care of your entire body. And every minute it's continuing to do this over and over again for the entirety of your life. That's a lot of work. The amazing heart, the very important heart. All right. So these are some factors that influence your stroke volume. So know that equation, know that stroke volume equation. If you want to rewind the video, go back through it. If you need a further explanation, just let me know. But you do need to understand that. So stroke volume averages about 70 milliliters per beat. All right. And so, but it can range from 50 to 120 milliliters. Exact stroke volume is a little difficult to get because of the ejection fraction and because of that ejection fraction is what is used. Percentage of blood that is ejected with each ventricular systole, which is equal to stroke volume divided by the end diastolic volume. So normal ejection fraction is about 50 to 65%, which should be about equal for each ventricle. 3 factors that influence stroke volume is your preload, your heart contractility, and your afterload. Right? Preload is the degree in which the stretch of your sarcomeres and your ventricular cells before they contract. So basically allows how much space your ventricle is going to can stretch to. That's the bigger the ventricle, the bigger the space in the ventricle, the more blood that can fill that space. So largely determined by your end diastolic volume, the length of time spent in your diastole. The more time you spend in that rest phase, the more time you have for blood to fill your ventricles. Amount of blood returning to the right ventricle from your systemic circuit, that's going to play a role. Your end diastolic volume increases when ventricles spend more time in diastole. Left ventricle pumps blood more forcefully in the systemic circuit. It's stronger, then more blood is going to return to your right atrium and eventually to your right ventricle. The more the ventricle is stretched, the more forceful the contractions. Stretching causes more optimal overlap of your actin and myosin. This is the relationship. Which can help increase your stroke volume. So basically, the more flexible those heart muscles, the stronger those heart muscles, the more your stroke volume is going to be. Right, contractility of the heart, its pumping ability. Increasing contractility will increase your stroke volume, therefore decrease in systolic volume. Contractility basically is your ability of your heart to generate tension. But basically, we know that if the heart is stronger, it can make a more forceful contraction. We do know that when the heart rate is too high, when your heart is beating fast, that the contractility decreases, as does preload, as you see here. Heart beats too rapidly. It can cause a decrease in both the stroke volume and the cardiac output. It's not necessarily good for your heart to beat too fast. That can actually be bad for you. So just you can go through this list and look at these different reasons why contractility can affect your stroke volume. And then afterload refers to the force that the right and left ventricles must overcome in order to eject blood. Blood pressure. This is where blood pressure plays a huge role. Remember, blood flows from high pressure to low pressure. So if there's high pressure already in your arteries because you have high blood pressure, your heart's going to have to work harder to pump blood through your body. Okay, so that's going to be an issue, and that can affect your stroke volume. That can affect the amount of blood that flows. The rate at which blood flows through your body. So a decrease in afterload generally corresponds to a higher stroke volume and lower end systolic volume. Okay. We want to keep our blood pressure down. How do we do that? We eat properly. Or if you have a medical or genetic predisposition to high blood pressure, you can manage it with some medications. Okay. Other factors determinant of cardiac output is the heart rate. Right. If cardiac output is related to your heart rate times your stroke volume, in general, if your heart rate is higher, your cardiac output would be higher, which is what happens when we exercise. Your body demands more oxygen, and so you increase your heart rate and therefore increase your cardiac output. But there are other factors that play a role when we look at heart rate and cardiac output. Factors that influence the rate at which the SA node depolarizes. Right, so this include the sympathetic nervous system, some hormones, elevated body temperature that can all increase your heart rate, therefore increase your cardiac output. You also have the parasympathetic nervous system. Remember your rest and digest. Parasympathetic digest, and you can have effects where you decrease your body temperature, decrease your cardiac output. Remember, even though the heart doesn't require you don't have to consciously think for your heart to beat. It is affected by the the nervous and the endocrine systems. They can influence your heart rate and your stroke volume. Remember when you talked about the autonomic nervous system, the ANS, and if you don't remember, you can go back through that chapter previously, but they can affect the heart rate. We're just going to go through it briefly here. So because this is talked about, you've learned about this already previously. All right, so the ANS, autonomic nervous system, innervates the heart through the sympathetic nerves, stem from the ganglia located along the spinal cord. Remember the spinal cord, and you have the ganglia on the side, on each side of the spinal cord. They release neurotransmitter norepinephrine, increases cardiac output. You also have norepinephrine's positive chronotropic effect, increases heart rate by raising the rate at which the SA node fires. That's how it increases your heart rate, so that it can get your SA node to fire up to 100, 180 to 200 more times per minute. Increases the entry of the calcium ions into the cardiac muscle cells. Right. So that's how your nervous system, your autonomic nervous system can affect, working together with by releasing norepinephrine can increase your cardiac output. Your parasympathetic nervous system has the opposite effect. Remember, your rest and digest innervates the heart by left and right vagus nerves. This is one of your cranial nerves, cranial nerve 10. Releases acetylcholine, primarily affects the SA node as well, decreasing the rate of action potential generation, slows the heart rate. It can even temporarily stop the heart if it's strong enough, which would not be good. We don't want to stop the heart ever. Vagus nerves primarily innervate the atrial muscle, have less effect on the ventricular contractility of the heart rate. All right, so sympathetic is going to affect the AV node, norepinephrine, raise the heart rate. Your parasympathetic through the vagus nerve, it's going to release acetylcholine, also affect the AV SA node. They both affect the SA node. I don't know why I said AV. Decreasing the rate of action potential. This is a diagram of that. All right, your chain ganglion affecting the SA node and the ventricular muscle cells. Your sympathetic, your parasympathetic vagus nerve also can affect the AV node and SA node, slow down the heart. That was the nervous system. Now we have the endocrine system. Remember, the endocrine and nervous system both play significant roles in controlling the body. So we have the adrenal medulla. Remember you may not remember the adrenal medulla, located by the kidneys, is activated by sympathetic nervous system. That's your fight or flight. And in response, it secretes epinephrine and norepinephrine into the bloodstream, which have same effects as sympathetic nervous system, but the effect is longer lasting, so they can increase the heart rate that way. And then you have the amount of water in your blood volume plays a significant role in determining heart's preload and therefore its strength of contraction. So hormones such as aldosterone, an anti-diuretic hormone. And we're going to talk about these a little bit more when we talk about the urinary system, but they can increase blood volume. Remember, if your blood has more water in it, it's going to flow faster. Okay, so that raises cardiac output. Whereas the atrial Natriuretic peptide decreases blood volume and preload and therefore reduces cardiac output. If your blood flows slower or is more viscous, is thicker, then it's gonna reduce your cardiac output. Right? So hopefully that all makes sense. Right? So these hormones can play a role in increasing and decreasing your cardiac output by increasing and decreasing the amount of water, increasing or decreasing the amount of water in your blood. So that's always important to drink water. Like I said before, when you go and give blood, one of the things they say is to drink water because your blood flows better. If you give blood quicker, it'll take less time for you if you're properly hydrated. Some other factors that can change your cardiac output: concentrations of electrolytes, your body temperature. Your SA node fires more rapidly at a higher body temperature. Your heart beats a little bit slower at a lower body temperature. Age, and things change as we get older. Younger children usually have a higher, as I mentioned with newborn children, have a higher resting heart rate, and children in general tend to have a higher resting heart rate, whereas trained athletes often have a much lower resting heart rate. And as we get older, usually have a little bit slower heart rate. So things like exercise are good for you. Increase it also because it increases stroke volume. So your heart doesn't have to work as hard when you're resting. And this is just a diagram just showing you different ways your body can control your cardiac output. Sort of putting together the last couple slides, different ways your body can influence cardiac output. Unfortunately, when we talked about the coronary system, we talked about myocardial infarction, heart attacks, and things like that. You can also have just heart failure, which is any condition that reduces the heart's ability to function effectively as a pump. And I've mentioned it. The heart's very important muscle. So we don't want anything clearly to happen. Heart failure can include myocardial ischemia, myocardial infarction. That would obviously be failure because part of the heart is dying, not getting a blood supply, therefore it's not able to pump. But you have these diseases of the valves, any disease of the heart muscle itself, electrolyte imbalances. Heart failure results in decreases in stroke volume. The heart's main goal is to pump blood throughout your body. So when it starts to fail, then stroke volume decreases. The amount of blood being pumped per beat will decrease. Symptoms of heart failure: pulmonary congestion, blood backs up in the pulmonary circuit. That's not good, obviously. The blood flow increases pressure in these vessels. You have swelling or fluid in your lungs. You don't want fluid in your lungs. Pulmonary edema forces fluid out of the capillaries into the tissues. Visible swelling in your legs and your feet because of the fluid's the blood's not being pumped properly, and therefore fluid tends to come out in your legs and feet, and that's not good. Remember, that's like the furthest point away from your heart. So being able to get the blood all the way down to the feet and then back up to the heart is hard to do. It usually takes a healthy heart to do that. And so when the heart starts to fail, how you see it is that fluid can't get back up to the heart, and then you start getting swelling in your feet. And that's a sign of heart failure. unfortunately. Think about that. Hopefully that makes sense. If not, I can explain it to you further. Treatment usually includes lifestyle modifications, weight loss, exercise, eating right. You can have sometimes you need drug therapies. We're going to talk about the kidneys and how they can play a role. I'm sure everybody's probably heard of dialysis. And you have these dialysis centers all over the place. That's usually kidney failure, but that can sometimes be related to heart failure. And in some cases, you need a heart transplant or a pacemaker installed. And so there's obviously a lot of medicine around the heart, because it is such a vital organ. And when it starts to fail, usually that's a bad sign.